So when we talk about transition, why is it important? And why do we think that transition is important for congenital hyperinsulinism? And, people have been talking about transition, meaning that, how do we actually move children or young people from pediatric clinic to adult clinic? And it's been going about for last 15 years. But in particular, when we talk about hyperinsulinism, we know that this condition needs multidisciplinary team input. And they sometimes need, young people would have need to see dietitian or psychologist or a developmental pediatrician or somebody from adult team who could actually help, when young people are in university. And when they are young adults with hyperinsulinism, they have complex requirements sometimes, and they have to be supported, like they are supported through their sort of childhood. They sometimes need to be supported when they are adults. And the best way is obviously trying to plan that services, trying to plan it in such a way that it's just not a shock for the child, for the young person, or for the family, when they're moving from the pediatric to adult services. And that's why it is, and that's why it is thought to be very challenging. So it's important to start planning ahead, especially when they sort of are doing their A levels or they're planning to go to university, and how they can really manage their condition themselves. When we talk about transition in pediatric conditions, the Care Quality Commission and Department of Health have published several guidelines over the last 15 years. And if you look at it, I think I can do is it working? Yeah. If you look at the transition here, you can see that in Department of Health in 2006, they had published about getting it right for young people. So yeah, they've been talking about for last more than 15 years, and a lot of things have been going into that, why transition is important. And if you look at some of the statements which had come out from Care Quality Commission, what they felt was that commissioners must listen to about and learn from young people and their families. There is existing good clinical practice, and that must be followed, for all the conditions. So yes, there are certain conditions that really have good transition pathways, but then, people need to start learning for other conditions as well. GP should be more involved, because what we do is, obviously there are always hospital doctors or pediatricians who are involved, but sometimes, the GPs are not aware of it, and they should be they should be involved in planning transition, so that, because once they become adult, they actually are going to see the GP, and most of the times, and obviously the hospital consultant. So they should be involved as well when you're planning transition. And then adolescence and young adulthood should be recognized across the health service as an important developmental phase. And this was what they had reported, and that's where it's important to have this planned well in advance. And again, these are the publications from Department of Health about planning transition service and why is it important. National Institute of Clinical Excellence, I don't know if you've heard about NICE. So NICE UK is an organization where they've published quality statements regarding transition. Statement 1 is young people who will move from children's to adult services, they start planning their transition with health and social care practitioners when they are in year 9. So around 13 to 14 years of age. So you start thinking about transition when they are about 13 to 14 years of age. And you can see that why is that important. We need to start discussing with family and the child, or immediately if they enter children's services after school in year 9. Statement 2 was young people who will move from children's to adult services have an annual meeting to review transition planning. So when we start discussing about transition, it's important that we discuss every year, and there might be certain things that they might want to discuss and until they are 18, and then eventually they get transition. Statement 3, young people who are moving from children's to adult services have a named worker to coordinate care and support before, during and after transfer. Statement 4 was young people who will move from children's to adult services meet a practitioner for each adult services they will move to before they transfer. So what we do there are established transition clinics, as I mentioned, and especially like condition like diabetes, when you think about it, it's done really well. And we have an adolescent nurse who actually look after adolescent as well as they look after young people and young adults. So it's really nice that actually that nurse follows both side of journey when they are in pediatric side and as well as in the adult side. And actually then there is like at least for 1 or 2 years, both pediatrician and the adult physician will be sitting in the clinic together, seeing the family together. So that's really important, that actually, you know, the handing over of the care is smooth, it's done nicely, and they actually see both teams, you know, together for at least a year. And statement 5 is young people who have moved from children's to adult services but do not attend their first meeting or appointment are contacted by adult services and given further opportunities to engage. So again, that's where, you know, sometimes they just lose, you know, they don't attend or follow up, and it's important that actually when we hand over the care, at least the adult services keep contacting and try and engage with them. And how is it, you know, possible to do it? And why, you know, it's important to actually make sure that we meet the team and have joint clinics for smooth handover of the care, as I mentioned. You know, team involving both pediatric and adult diabetologist or endocrinologist, psychologist, dietitian, sometimes nurse specialist like we have in transition nurse, and then if depending on other MDT members who we may need, depending on the need, and you know, like from community services or involve GP or you know, social care. We actually did, when we started this transition clinic 4 years ago, when I was at GOS, you know, we did some kind of surveys, and I've just put few sort of comments from parents, and what we had was that, you know, child had no hypo-awareness, she's made gains in managing her condition independently, but continues to need support. You know, she needs to have a direct access to expert nursing advice as she reduces her reliance on her parents. We really needed support and advice from someone who really knows the condition, you know, of this child, and who understands this complex and unstable condition. It's been very stressful, was unable to begin college until 6 weeks into the term due to the challenge of supporting her in the college with her HI. So the transition clinic would have been ideally placed to support with this. One of the other parents mentioned that it feels highly essential as a parent to know before and who they will be seeing in future, and think the meetings and shared consultations are vital to understand the complexity of the condition, which actually differs from, you know, child to child, as we know. As parents, they feel is being treated like a young adult who is slowly moving into looking at her own care and taking control over her future medical needs, which is essential for her as she will be able to be somewhat independent in her medical needs. And this is what always comes up in discussion, is that how do we really, you know, place that young person, you know, managing that condition on their own and doing that independently. So what are the barriers when we think about it, you know, to do this? You know, barriers that prevent optimal self-management, that includes, you know, there are heightened concerns about peer relationship and social interactions. There's always frustrations and fatigue from the management of this chronic illness, and, you know, it is very natural for somebody just to feel tired of it, and because they've been doing it every day, you know, they just get fatigued from it. There's incomplete knowledge and sometimes an understanding of this chronic disease and management. There's inclination towards then risk-taking and difficulties in the transition to self-management. And those are the challenges we may have, especially, you know, when we are doing this transition. So when we started, and I think all transition clinics should have some kind of aims as why we want to do it. And I think in terms of hyperinsulinism, when we think about it, we should think about what the national guidelines are there and what we think would be applicable for this condition. So what we want is that we want to support education, empowering self-management, addressing parental and caregiver concerns, addressing ongoing medical issues or needs, dealing with impaired awareness of hypoglycemia. And we talk about this so many times that actually, you know, young person or adults are not able to actually have any, or they don't have any symptoms of hypoglycemia. And how do we really address that? Providing advice around driving, providing support to higher educational institutions and those in employment, preconception genetic counseling where appropriate. They might continue to need dietetic advice sometimes, and then alcohol and recreational drug advice too. When we talk about medical issues encountered in young people and adolescents with CHI, I've divided into two things. One, those who have confirmed genetic mutation. One, those actually do not still have a mutation, mutation found. So when we talk about genetic mutations or those who have confirmed genetic mutations causing CHI, it's important about symptom control. They need to know about the risk of developing diabetes, or sometimes they might already have developed diabetes in those who did not have pancreatectomy, or those who might develop diabetes, those who had pancreatectomy. And also obviously impaired hypoglycemia awareness and how it can lead them to be at risk when they are out and about on their own or with their friends. And those who actually do not have a mutation, then obviously we need the top as well, but also it's important that we continue to have those exploring genetic diagnosis, because it's really important that to help them to understand the cause of it, but also then what's going to happen in future. And that's why it is really important then for counseling as well. In terms of developing transition pathways, and whenever we think about having a transition clinic, there's other things that sometimes we have to think about it. So we always have to think about is there a gap? What are the gaps? We need to identify the gaps. We actually have to have, most importantly is the parents, families, and the young person who actually would be helpful in designing any kind of service, and how really they can help to sort of they can help in terms of designing and ensuring that all their needs are addressed. We then go to planning, so planning a service, and then go to the planning for transition. So what we need to think about timing, we need to think about a named worker, about who would be, will be able to transition for, or will be the contact details, when young person goes from pediatric to adult clinic. Having a peer support sometimes, thinking about having a peer support who actually might be helpful, building independence, and then obviously involve parents and carers. And then before transition, to starting having joint clinics. So before the child or young person moves from the pediatric to adult clinics, it's important that we have a joint clinics, multidisciplinary team approach if possible, sharing data with adult services, and also involving other MDT members. And then outline what are the services available to the young person before they go to the adult clinics. I just have got some data, and when we started transition clinic, we just want to get some feedback from families. And what we found was, so we had 40 children who were transitioned, and transition meaning about 14 years. So we obviously we're doing a joint clinic, and we wanted to start involving young person, after 14 years in transition clinic. It was once a month clinic, which was a joint clinic between the pediatric and the adult physicians, and we designed a short survey just to get a feedback from families and the young person, and what we found was 100% of the young people and the parents and carers found that the transition clinics were useful. Young people and parents and carers felt that their expectations were met and received sufficient information about the clinic. But we also wanted to know how we can improve, because it's always getting things right and improving from what you do. I think there were a few things that they felt that, the venue of the clinic details, they were not very clear, because obviously when going into the adult services, it was probably in one small room in a building, and it was really difficult to find that. So they were like, we wish we would have that more information, and then chance to meet other young people. So I think that's something we would like to discuss today, is what you guys, all you feel about, having peers, and meeting other young people. But also they found very encouraging, they found approachable, listening and supportive. So it's really important to have all those kind of things planned ahead. So just to conclude, I think transition is a really, really important aspect of the child's health needs, and it's really important to plan ahead. And it's knowing with congenital hyperinsulinism, it's a complex condition. We need a multidisciplinary team support, and because of all the comorbidities associated with it, whether it is hypoglycemia, persistent hypoglycemia, or developing diabetes, or any other comorbidities associated with it, there is a need for identifying healthcare professionals when they go into sort of adult clinic. Thinking about parent and patient leaflet about transition, and sort of giving them a bit of background so that young person can also understand that actually this is something I'll have to do after a couple of years. There is something called patient ePassport, transition ePassport. Now, it's come up in the Department of Health guidelines and other guidelines too. And what they start doing it is, I think, you have a small card, in your wallet or wherever you go, and to have about your condition, your contact details. So when young person are actually going out with their friends, carry something that has got all their medical details or information about the medical team. And that's what they were thinking, that's what been advised for other conditions. And thinking about that, maybe at CHC we can think about, having those kind of ePassport where you can carry it with you and who your treating physician is and the contact details. And a young person forum, and really I think crucial, that you share stories, you learn from each other.
We went through transition with you at Gosh. And Katie turned 20 this week, and we're still going through transition because of COVID. We were then transferred back to local care rather than having to keep travelling backwards and forwards to London, and they continued the transition at Luton and Dunstable, as well with Dr. Banerjee and Dr. Nathwani. And then next month, Katie has her very first adult appointment. But they've asked for me to go along for the first one as well, so that it's not just a, right, you're on your own now type thing. And I think it's really important, isn't it? And it alleviates a lot of anxiety.
Well, that's really, that's true. I think we do see, it's really different, but we do see that. And I think there's, for parents to come around just to feel that confidence. And that's why if we start a bit early, if you have 2-3 years, then it will become, for the young person, they will become more confident. And at the end, after 18 years, actually, the young person is going to decide where where they want the care to be, because sometimes they feel they don't want to travel all the way, but they can manage it well. Or sometimes they may feel that, no, I'm happy to travel and I'm happy to do that. But yeah, it's nice that obviously with COVID there were a lot of challenges, I guess, so it was really difficult to do transition during that time. But now it's good that you've got...
it on Zoom.
Yeah.
With Gosh and
at St Mary's, yeah. Yes, you are. Yeah.
And then obviously then they decided it would be better to come back, so then we started going to the local care then.
Yeah. Which is, I think that's good that you've got that. And was your GP involved at all?
No, not really.
Okay.
I mean, he always says contact the hospital because he's just not confident with the condition, is he? So anything that the hospital asks, he will do.
Yeah.
But he likes it to come from the hospital rather than him making the decision.
Yeah.
To change her medication or to do this or do that or something.
No, which is good. In a way, at least they're supporting in a way prescription-wise and things. But if you feel that, sometimes if GPs they are not aware of it, because also what I've found is, I think when you become adult, GPs will be like your primary contact. In pediatrics, it's different than what in adults. And I think that, it's important for GPs to know as well. Yes, when they were little, GPs sometimes they would just get, oh, it's pediatrics, it's not my remit, please speak to your hospital. Once they become adult, you are, the GPs are actually your primary contact. So it's good for them to know as well. And obviously, I don't know how all the adult services work very differently in different places. So, but the good thing is, at least as long as your GP is prescribing what is actually asked for, which is great then. So.
Also, if you've under lots of teams, will they, obviously at the moment, if they want to all meet up, they can do that in Gosh, but when we go over 18, what happens then? If it's one condition and affecting another condition, what happens then? Yeah,
which is, I think it's a challenge, which is right, because like I was saying, you have got so many, you may have other conditions, which is, where you are under different specialists. From my experiences, I think, what parents feel, because sometimes, your local would have that great service, and if you feel that you have those other teams which is available, then you may want to have those sort of, for those kind of things locally. And other things you may want to have it under other teams. So it is true, it's a challenging thing. At the moment there's nothing like you can have everything under one roof. But that's how it is, unfortunately. So that's why it is also important to think about, when you start planning and think about, okay, if these are the services available which is near to your, where you live, then you may want to think about having those services accessible.
See, ours work a lot with the London hospitals anyway. So like King's and
Evelina.
Come to our local anyway for appointments.
Okay.
They do clinics.
I see.
So it's, I don't know, yeah. So
Yeah.
they do a lot of clinics. That's who they work with. So
Yeah, and in adult, I think in adult medicine is very different than what we do for pediatrics. And I think most of the adult physicians, they are pretty happy about, unless if they would say, no, please go to this. But if you speak to your adult physician, and that's where, once you get transition, you always have this opportunity after a few years, once you are into the adult clinic, where you may then want to kind of think about where your care is then sort of primarily based at. But if you are under different teams, that's a bit of a challenge, which I understand.
Yeah, it's a few teams, so it's difficult.
Yeah, but it's good to explore. I think it's good to discuss. See, again, that's why I feel, sometimes having this discussion with the GP or somebody who knows about the, the service, because they would know when they become adults, because they would know if they have an adult with that condition, they would be referring to somebody near to place, so they would know what kind of services are available. And you start having discussion is that this is what is being planned, what are the possibilities and what can we do.
Okay, that's fine. Because for us it's moving to the next step, because I know once you start the transition they want the child to become more independent, but our problem is the symptoms. So symptomatic that if they're out in hypo they don't know where they are and they're very vulnerable. So obviously for us, I know that's what they're talking transition, but that's a huge step when your child's so symptomatic that if they're out, anything could happen to them because literally they don't know where they are.
Correct.
I agree with that. But I mean, you were saying about the ePassport.
Yeah.
I made my own one for Katie so that like if she goes out, very often it's not that she goes out alone anyway. She's usually with her sister who obviously knows what's going on. But she's got all the contact details there so that if something should happen, and she's got the ice on her phone as well.
I was about to say that.
Yeah. That like somebody medically would be able to get in contact with me straight away, sort of thing.
Yeah. Do you know what ICE? Yeah. Which is, I think everybody started using ICE very often, and you can actually have as a screensaver. I mean, I know sometimes you may not like that have as a screensaver, but sometimes you may want to have that where people can just have a look, which is true. I mean, these are all the things that we feel that how they are going to manage this, and that's why this planning needs to be starting with sort of and that's what everybody says, that after 14 we should start talking about transition and think about it.
It's old, because we were told it was old, slightly older if you've had the pancreatectomy, still on medication. So we started at 16.
Yeah, I mean, see, transition clinics can be starting after, but this is what Department of Health and what, the guidelines, national guidelines, and whoever, any condition, it's not about congenital hyperinsulinism, any condition, I think people, what they say is start talking, at least start discussing about it, even though you don't see the teams together, but at least start talking about it so you can, think about what you would like in 3 to 4 years down the line.
Yeah, okay, that's fine.
So yeah, I would like to thank Hyperinsulinism Charity. Thank you so much for this opportunity, and thank you everyone for coming here. Thanks.